Thank you for that introduction. I am pleased to be here. I want to thank NDSC for having me out again to do this talk on medical issues in Down syndrome. What I found is the families who do come out here to the NDSC meetings tend to be fairly knowledgeable when it comes to medical issues, but I think there are certainly some things that we all can pick up from the new guidelines that have come out in 2011, and also some things that have come out in the research recently that we're aware of that are more modern issues in terms of medical issues that we think about in Down syndrome. So we're going to talk about some of the more typical developmental and educational issues that we see before we go into the current healthcare guidelines for kids with Down syndrome. And then I'm going to talk a little bit about the role of a comprehensive Down syndrome center. What is it? Why do we do what we do? And why would it maybe why would it potentially be important in your area to have a Down syndrome center, and how to get something like that started? So Down syndrome itself was described in 1846 by a guy named Edouard Onesimus Seguin in France. And he didn't actually get the syndrome, of course, named after him. That came to John Langdon Down in England in 1866. But they had a lot of theories about what caused Down syndrome for about 100 years, until Jerome Lejeune found out that it was chromosomes that were the basis of Down syndrome in 1959. And these are the pictures of them in order that you see here at the bottom of the screen. Down syndrome is the most common genetic condition that results in intellectual disability. About 1 in about 700 live births in the U.S. will have Down syndrome. There are about 6,000 new cases in the U.S. each year. But when you look at the conceptions, meaning pregnancies with Down syndrome, there's probably about 1 in 150. And that means that quite a few babies with Down syndrome either have spontaneous miscarriage or, of course, elective termination of pregnancy. We also know that with you have an increased chance of having a child with Down syndrome with what they call advanced maternal age, which once you go beyond 35 doesn't feel quite so advanced. But certainly it's what we call in the medical field as advanced maternal age. But still, it's important to realize that most babies with Down syndrome, in fact, most of the families that I follow in the center, have younger parents, and that's because most babies in general are born to younger people, and hence most babies with Down syndrome are also born to younger women. And when we think about the medical issues that result from Down syndrome, they all are related to the extra chromosomal material on the 21st chromosome. The 21st chromosome is the smallest chromosome that we have, yet when it comes in triplicate is when we see the issues that come up in Down syndrome. Usually it's related to what we call maternal non-disjunction, which just means that truly when the mother of the child with Down syndrome was in her mother's womb, the egg, when it was starting to divide while she was inside her own mother, actually had that extra 21st chromosome that hadn't separated as we would have expected. And then, when that woman becomes of age and then sperm and egg meet, that egg just happened to be the egg that comes out during that month, and hence you get the extra 21st chromosome. It's really something that comes out by chance. Most of the time, it's from mother's egg, but again, we never know. About 10%, well, here I say 7% of the time, it's due to father's sperm, and you never know, and it really doesn't matter. And I think that's an important thing for families, especially mothers, to know, is that whenever I meet them for the first visit, they always say, oh, this is all my fault. And I say, well, first of all, even if it was from mother's egg, it has nothing to do anything you could have done differently. And two, it could very well have also been the extra chromosome contributed by father's sperm as well. But when we look at the chromosome report for a child who has trisomy 21, you see here, indicated by the nice red circle and arrow, that you have a boy here with 3 chromosome 21. And this is 95% of the time, this is the chromosome report that we see. Translocation type happens 3 to 4% of the time. And what that means is that usually the chromosome 21 of the child with Down syndrome is usually attached to chromosome 14. And when we see the chromosome report for a boy with Down syndrome who has that type, it looks as if there is only 2 chromosome 21, but in fact he has a 3rd chromosome 21 here attached to the 14. And so this boy has Down syndrome. And the reason it's important to know if there's translocation type is because you'd want to check the parents' chromosomes in this situation, because it may increase their chances of having a child with Down syndrome in the future. And in this case, we see the father's chromosomes. It appears as if he only has 1 chromosome 21, which is not compatible with life, but his 2nd chromosome 21 for this father is sitting here on his 14. So he has a higher chance of future children having Down syndrome. And I think that's important for families to know the type of Down syndrome that their child has, so they know if there's any future increased risk. It's very important for us to recognize, my brother has Down syndrome, and even when my wife and I were having children, it was the OBs were not really well familiar with what the different types of Down syndrome were. My brother has the trisomy 21 we were just talking about before, and in that situation, there is no increased hereditary chances for future babies with Down syndrome. And I think that's important not only for you to know as parents if you're going to have future children, but also for your other children to know that their chances of having a child with Down syndrome is no higher than the general population, and there's no reason they need to undergo any more invasive testing than anybody else. And then there's mosaic-type Down syndrome, which is the least common of the type, and also the most interesting in terms of we don't really understand it very well. Mosaic-type Down syndrome means that sperm and egg met inside of mother, and initially the baby had 46 chromosomes, and then along the division process, there was a time where an extra chromosome, 21, went into that division process. And it's very interesting because we have several families that we follow with mosaic-type Down syndrome in the Down Syndrome Center in Pennsylvania where their mosaicism is only found in certain cell lines. So we have a couple of girls who we only discovered they had Down syndrome because they developed a type of leukemia that's only seen in Down syndrome. And when they did the bone marrow test, only their bone marrow cells had Down syndrome, and the rest of their body did not. And so there's probably more people walking around who have no idea that they have mosaic-type Down syndrome because it maybe hasn't affected their development, maybe because their extra chromosome 21 didn't go into their brain cells or didn't go into their heart cells and didn't cause any of the problems that we maybe see in Down syndrome. So anyway, mosaic-type is very interesting, and a lot of people are doing research into what exactly causes mosaic-type Down syndrome. I should have mentioned earlier, and I'll mention it now. If you guys have any questions at all during the talk, just write them down. There's going to be more than enough time at the end of the talk for us to go through any questions that you may have. But I may answer some of them as we go through, so let's just save it for the end of the talk. So I just wanted to very quickly go through some of the common findings that we see in Down syndrome, mainly because a lot of what we see physically is what ends up causing a lot of the medical issues and helps us to understand a lot of the medical issues in Down syndrome. This table goes through a lot of the findings that we see commonly in Down syndrome. Some of the ones that we think of most commonly about Down syndrome, for example, the single palmar crease on the hand, is actually some of the more least common type of findings that we do see. And I think that's important to know. And some of us may have some of these features, yet don't have Down syndrome. So important for us to recognize that it's a constellation of symptoms that make the doctors suspect Down syndrome. Hypotonia, or low tone, is the most common thing that we see in the babies with Down syndrome. And generally, you can see here in this picture a pretty significant example of hypotonia where this baby is giving no resistance at all to the examiner in this picture. And it's important to know that muscle tone and muscle strength are two very different things. I have some friends with Down syndrome who are adults now, and they're weightlifters. And if I was to sit down and arm wrestle them, they would beat me within 2 seconds because they have huge guns. But when they were babies, they were very hypotonic, I'm sure. And so strength and tone are very different things. Tone is our resting muscle. So when we're not thinking of anything, like when we're sleeping or when we're not thinking of actively contracting our muscles, that's our tone. Our strength is when we decide to pick up that barbell and lift it. That's our strength. And those are two different things when it comes to muscle anatomy. And we look at the typical facial features that we see in kids with Down syndrome. This baby, we can see some slanting of the eyes and what we call epicanthal folds here. This baby also has a flat nasal bridge. This baby has, I think, my favorite finding in Down syndrome, which are the brush field spots around the eyes. There's absolutely no visual consequence at all. I think it just adds beauty to their eyes, which I think is a very fascinating thing. If they're blue-eyed, we see them more frequently than when the kids have darker eyes. This baby we can see has some significant low tone, especially in the mouth. You can see how the tongue is protruding primarily because of the mouth hypotonia there. This is not a baby, thank goodness, for the mother who may have been breastfeeding. But this child has a very high arch to the palate, and what that does is it lends itself to feeding difficulties, especially early on in life. Because of the high arch to the palate, it makes it hard for the babies to maintain an effective suck. And then also, as they get older, it can lead to speech difficulties as well. So we do look for high arches to the palate. This baby has a folded over pinna, what we notice here. And ear anomalies are more common in kids with Down syndrome, and things that we look, another feature that we can see in Down syndrome as well. Extremity findings, this is that single palmar crease. There are very derogatory terms for a lot of these findings, so I want you guys to know the right terms so you can correct somebody who says the wrong ones. So single palmar crease, this is a wide space gap between the first and second toe. And this is what we call clinodactyly, or fifth finger that kind of curves inward. And these are all findings that we do see, again, in people who don't have Down syndrome, but also in more frequency in kids who do have Down syndrome. But you put it all together, and you get a very cute baby very often. And I think, this is a family. She gave us permission, of course, to use her baby's picture in it. And she's a newborn photographer. I'm glad my wife did not know that there were newborn photographers when we were having newborns, because I'm sure they might be costly. But it's kind of neat to see how they can pose the baby in different ways, because her baby is very hypotonic. And I said, well, how did you get the hands to rest there? And I guess Photoshop is an amazing thing when you're a newborn photographer. You can do many things like Photoshop out hands that are holding the head in place. But anyway, you put it all together and the babies are generally very cute. Developmentally, we do expect to see some areas of delay in most areas of development. Usually, we see some gross and fine motor delays. We're going to talk, I'll have a table that shows some of these here in the next slide. Some cognitive issues, but it's important for us to recognize, and I think there's a lot of misinformation out there about the level of intellectual disability that we see in people with Down syndrome. It's very mild generally to moderate. Severe intellectual disability is very uncommon in Down syndrome, and so I think that's important for us to recognize. And language-wise, expressively there may be some delays, but receptively the kids with Down syndrome do remarkably well. You can tell your 1-year-old, where's your bottle, point to it, and they'll do it. But if you ask them to say the word, they may have a hard time saying it. So receptive, good, or better than expressive when it comes to language in Down syndrome. Kids with Down syndrome tend to excel in some areas of development. I think socially, most of the kids that I follow, that's what makes it fun to be, working in the Down syndrome center. It's because socially, the kids are usually excelling beyond their age-appropriate peers. And so I think that's an important thing for families to be cognizant of, especially early on, when all they hear from many of the doctors is a lot of negative things. I think sometimes we forget the positive areas, and I have a slide dedicated to that here at the end I'll show you as well. So when we're talking about the development, it's important to recognize that almost all of the kids attain the developmental milestones that we look for, in terms of walking, talking, all the type of stuff. We just have to be patient as parents and caregivers with when they'll come. Usually the kids get to those areas of development about 1.5 to 2 times. It takes them 1.5 to 2 times as long as perhaps a typically developing age-appropriate peer. So when another child may be talking at 10 to 12 months, the kids that I follow in clinic usually are saying their first words around 16 to 18 months. Again, this is a range. I have some kids that follow right along the same developmental pathway as everybody else that they have, age-appropriate wise. And then I have some kids that take a little bit longer. But it's all a range, and I think it's important for families to recognize when they may have heard from their OB or other care providers that your child will never walk or talk. I mean, these are some ridiculous statements that still go on today. So it's important for families to recognize that they get to these milestones. It's just up to us to be patient. And some of the fine motor and self-care skills, especially bowel bladder control, is one that we talk about a lot in clinic. It's a little bit delayed, especially in the boys. Just like in kids who don't have Down syndrome, boys take a little bit longer than girls to learn some of these skills because we're busy wrestling, I think, is what it is. But no, it takes us a little bit longer to learn this stuff, and especially in Down syndrome as well. We may be talking about toilet training well into the school age, and I think that's an important thing for families to know as well. So developmentally, the most important thing that families can do is get referred to early intervention services. Every state has different quality and different availability, but federally they are mandated to have some sort of early intervention service provided to families. And those are from 0 to 3 years of age, and it includes child developmental specialists, but of course also PT, OT, speech therapists. And there they'll develop the IFSP, or Individualized Family Service Plan. And those are in the first 3 years of life, typically in-home services in many of the states. We're pretty blessed in Pennsylvania to have really great early intervention services, but we recognize, as actually we've had families who move to Pennsylvania because of the early intervention services, because their state doesn't have quite the same type of services. So it's important for you as families to advocate for your kids, to know that these are federally mandated services, and it's important for the state to provide them in a way that best services you. And then after 3 years of age, it goes to the local school districts. And just like you can imagine, it really depends on the quality of your school district, which would be the quality of the therapy that you're going to be getting. But again, you are your child's best advocate, and it's important to advocate that the school doesn't slack in what they're supposed to be providing for your child as well.